All right, great. Well, why don't we get started? It's 9:02. So this is Adam Gaffney. Just want to start off by thanking everyone for joining this call. Really excited to do this webinar. I hope it's useful and helpful. And we can certainly carry on the discussion both during the question and answer period and also after the webinar is over in the coming days, weeks, months, years. So I was asked to talk about the pharmaceutical reform proposal that PNHP and Canadian Doctors for Medicare recently released. So I should, what I'm going to be talking about is the proposal published recently in the British Medical Journal, Healing and Ailing Pharmaceutical System. And it was put together by a group, US-Canadian Pharmaceutical Working Group, that I co-chaired along with Joel Lexchin, who's on this call as well as a writing committee and a working group whose names are on this slide. And it was sponsored by Physicians for National Health Program that sort of instigated the group getting together. And, you know, the idea was that we are at a crossroads when it comes to not only the specific issue of healthcare reform, but of pharmaceutical policy. And the document, and so this group came together to try to outline a comprehensive reform proposal that would really give us a platform when it came to the question of drug policy that addressed all the problems in the drug system, not only the prices. In this, the proposal deals with both the U.S. and Canadian healthcare system. I'm going to focus on, in this presentation, on the U.S. side, just given the time constraints. But as I may mention once or twice, many of the issues, if not most, or maybe even all, are common to both nations, even though Canada does a better job of controlling drug prices to some extent. So let's dive in. So drug prices are at a tipping point. You hear this, and every time you pick up the newspaper, problems with drug prices, straining household budgets, straining government budgets, straining the budgets of Medicare, of insurers, people going without needed care, people going without insulin, people skipping necessary treatments. You can't avoid it, and it's being discussed in Washington. Trump obviously had his big pharmaceutical reform proposal that came out recently. It was being discussed today in Washington. And so we need a platform because this is an issue that is extremely important to the vast majority of Americans. And it's an issue that we need to have a platform that goes beyond drug negotiations by a single payer, as important as that is. So this proposal came out recently. It got a fair amount of press. More or less stating that doctors in the US and doctors in Canada had come out with a fundamental reform proposal. And some of these write-ups sort of summarize some of the main points I'm going to be making. So when we went about this, and what the proposal does is it looks at not just the problem of drug prices, but it looks at the problems throughout the pharmaceutical system. And really that begins with the development of new drugs, and it extends to the next stage, which is clinical testing. The problems also inflict the process by which drugs are approved, how they're promoted, how we surveil them and make sure that they actually are safe if they're going to be in the market, how we price them, and then how we ensure that everyone has access. And I'm going to go a little bit in the reverse direction by starting with access. So again, access and costs are related, but not exactly the same thing. Many of the drugs that we're talking about are quite expensive, would remain quite expensive even under a single payer plan. And so we need to work on both sides. So what's the problem with access? The problem with access in this country is that in addition to the 28 million uninsured, there's many people, certainly more than 40 million, but probably much higher, who have insurance plans but still have to pay a lot out of pocket. And this was an article in Kaiser Health News outlining all the patients with cancer, including some on Medicare, who were skimping on therapy, skipping dosages of medication because they couldn't afford it. So how does this play out internationally? This is a graph that shows the basically cost-related non-adherence, which is just a fancy way of saying people not taking drugs because they can't afford it, among older adults. And you can see that we're the outlier on the far right. About 20% of U.S. adults who are below average income, so half the country, are skipping medication because they can't afford it. Even those above average income, about 10%. Canada is right behind us. And then you can see as you go farther to the left in this slide that other countries do a much better job of ensuring that people don't go without medications because of cost. And in some countries, there's not even a difference based on income. And so they've really gotten rid of your economic status as a factor in who can afford drugs and who can't. Honing in on the United States, again, it's a problem of certainly the uninsured, with 35% of the uninsured not filling prescriptions or skipping dosages because of cost, but nearly a quarter of the underinsured. But even of the people with insurance who are not considered underinsured, a lot of insurance is not good. Most insurance is not good. Even of those folks, 10% are missing medications. That's a lot of people. And the problem, again, is not just drug costs. It's the way we cover drugs. So what do I mean by that? I mean copays and deductibles on drugs, which would be burdensome even if drug prices came down. Now, copays and deductibles are bad because they cause people to skip care. And there's real consequences. One study showed that transitioned people into a plan that had higher copays on statins and on clopidogrel or Plavix, found that they reduced copays, found that by reducing copays, they reduced admissions or hospitalizations by about 10%. So that means that we're 10% more people basically are getting into the hospital because they can't afford medications, they're skipping the medication, and they're getting sort of hurt by it. There's even a randomized clinical trial of people who had a heart attack, and they randomized half the group to free cardiac meds and the other half to copay cardiac meds, and they found that the blue bar is free drugs and the orange bar is those who get copays, and they found that having copays increased the number of people having vascular events like heart attacks, as compared to people without copays. They also found that even though charging copays reduces how much you spend on drugs, which is the first couple columns there, it actually causes an increase in non-drug spending, so because people are going to the hospital more. So basically, this randomized trial of zero copays versus copays found that even though the copays reduces medications that people take, as a consequence to that, they have more heart attacks or other types of vascular events. And so even though less is being spent on drugs because people are taking less drugs, more is being spent on other forms of care. So it's not even saving money at the same time that it's inflicting medical harm. It also found that the copays adversely affected non-white people versus white people, probably because on average minorities have less economic resources. And so these are the way we structure our access is compounding the problems that are built into our healthcare system, including disparities. And I'm going to focus on the proposal. I just want to get a little bit of background here to give a sense of why we sort of felt the need to be as radical as we were in this proposal. People who have copays also don't take medications like inhalers. There's a study in Canada in the province of British Columbia, there was no copays before 2002 for older people, but they introduced them in 2002. And they found that by introducing these copays, older adults decreased their use with people, these people with airway disease like asthma or COPD, decreased their use of inhaled long-acting medications by more than 12%. And they found that those same folks also wound up in the hospital more. So when they started, the number of people being admitted for COPD, the first bar full, once they introduced the copays, the number of people being admitted for COPD increased, and then when they added drug deductibles, it increased even more. So it's doing real harm. And then there are alternatives. In UK, Wales got rid of all of its copays for medications about 11 years ago now, and did that cause the universe to explode and a black hole to form and pull us all in because suddenly there's no copays? No, it didn't. This is a chart showing the years when there were copays, which is the blue bars, that's the copay in pounds, £6, 4, 3, 2. And then in 2007, they got rid of all copays. And the orange line shows the change from the previous year in the number of items prescribed. So there was no increase in the number of prescriptions after copays were gotten rid of in Wales. So let's put this all together and focus on the problem of access. What is in the proposal? So what we say is that all medically necessary medications should be included in a formulary covered by the single payer plan. We say that if there are more than one drug that does the same thing, that have the same efficacy and the same safety, then we should cover the least expensive of those drugs. We say that that covered drugs should not have copays, coinsurance, or deductibles for all the reasons that I said. It does harm, it increases costs for certain conditions, increases disparities. And finally, we say that in situations where someone needs a specific drug because of an allergy, for instance, that's not in the formulary, that should also be fully covered. So that's problem one, access. All right, let's move on now to the issue of drug costs. So this is very much in the limelight and gotten a lot of attention now. So United States spends a lot, is an outlier in the world when it comes to drug spending. This is per capita drug spending in dollars in 2015 in the United States compared to other European countries as well as Canada. And you can see that the US, Switzerland, and Canada are the highest, the US being even the highest. And we're spending about double the median of other OECD nations, so about twice as much. And if you compare us to a country like Denmark, we're spending way more, like more than three times more. Now, the common, sort of refrain to this, if you bring this issue up, would be, well, yes, but we need this in order to, have research and development of new drugs. But it is not the case. This was a really interesting study recently that looks at the R&D costs of a new drug versus the revenues that those drugs produce. And so the authors looked at 10 drugs and they followed them up for 4 years after they were approved. And they found, as you can see, that the total R&D spending was less than $10 billion, whereas the total revenue from those same 10 drugs was more than $60 billion. So it's not going to R&D. We also know that profits are much higher among drug firms as compared to other firms. Over 20% profit for drug firms in the Fortune 500, and a little bit over 5% for other firms, around 7%. And we know that drug companies can, because many drugs or most drugs that are not generic are basically monopolies, drug companies can more or less charge what they want for those drugs up to the point of inciting a riot, basically. People refer to this as much as the market could bear. And so this is, insulin, we've seen this. Insulin's a drug that's been around, developed in the 1930s in the University of Toronto. And it's been around for a long time. It's been modified and there are new versions, but the price is being rapidly escalated now. Trump's Secretary of HHS, Alex Azar, was a former executive at Eli Lilly, and he was, at the company at the time in which he was jacking up the price of insulin. And this doesn't have anything to do with research and development. Martin Shkreli, obviously, jacking up the price of a drug from the 1950s has nothing to do with research and development. Mylan Pharmaceuticals jacking up the price of EpiPens. Epinephrine's been around for a century. The injector device that they use is a modified version that's been around since the 1960s when the U.S. Department of Defense basically came up with this auto injector that was supposed to be used for nerve gas attacks. So these are old drugs that the prices are being jacked up on. The new drugs, the prices are being jacked up on, and you can't attribute that to research and development. Also, we know that pharmaceutical CEOs make an absurd amount of money. tens of millions of dollars a year for all the major drug companies. All right. Well, are there solutions, and what are we outlining? And I wanted to say briefly that there's a lot of material in this proposal, and it goes through, so as I said, sort of every step in the drug development pathway. So I didn't try to go into insane depth on each individual point. I want to get through the sort of big picture stuff and then leave time for questions and discussion. And I will say also, I have the chat message open. So if there's a sort of a question very pertaining to something I'm saying, feel free to type it in, and as long as I see it, I'll get to it. So let's talk about some of the solution to the prices of costs, to the issue of costs, again, which is a separate issue than access, although connected. So the first is what people refer to as drug price negotiation. So this has long been something that has been in PNHP's program. It's a general term that refers to what happens in most nations when a government agency, the payer, basically in some way either negotiates directly with drug companies, has regulations, has something called reference pricing, where they set the maximum price of a drug based on what's going on in what it's charged in other countries. Either way, this approach to bringing down drug prices is clearly works. The Veterans Affairs does it, and they have drug prices that are probably around half as much as we pay in the private sector. Medicaid brings down drug prices to a certain extent through regulations, a different approach, and other nations succeed in bringing down drug prices. And we estimate, just sort of surveying what other countries get, that we could bring down brand name drug prices by about 50% through these sorts of negotiations. But I'm going to talk a little bit about other things. So that's not always going to result in the answer and not always solve the problem of high drug costs. And why is that? Well, what happens if there is only one drug that does the trick? And this is increasingly the case when drugs are sort of developed for narrow indications, certain kinds of cancer, rare illnesses. There may not be 5 drugs that the payer can sort of negotiate between, or 5 different firms that the payer can negotiate with. There may only be one, and when there's a monopoly like that, then the government has none of the then the drug company has all the cards and can walk away from the negotiating table. And so, that may have been the case, with hepatitis C drugs. That very well may be the case, where now there's more of them, but at least early on there was few. So we get into something that's getting a lot of attention now called compulsory licensing, which basically allows the government to green light the generic production of a brand name medication prior to expiration of the patent in situations where it's medically necessary from a public health perspective. I'll get back more into that. The other 2 things we talk about in the proposal, which I'll get into a little more, are public production of drugs in certain instances, as well as a public drug development division within the National Institutes of Health and the corresponding Canadian agency. And again, I'm sort of focusing a little on US here, but everything applies to Canada, that could develop drugs outside the patent system. So let me talk, I already sort of got into the drug negotiation process. And so would that work? And as I said, there's good examples that it would. So the other slide that I showed in terms of drug spending, that's overall drug spending, right? So that doesn't tell you if we're spending more because we're using more drugs, or we're using different drugs, we're using more expensive drugs, or are we actually paying more for each actual given medication? And so we are, in fact, paying more for each medication. So prices are higher. This is a chart just showing the sort of relative prices for the 30 most commonly prescribed medications. It's about 10 years old, dated now. But basically, the United States is the reference and set at 1. And the y-axis shows sort of the fraction of U.S. prices that other countries are paying, and you can see that the median is about half, about 50% of what the United States is paying. And again, Canada's on the high end there. So this is data enough to demonstrate that negotiations can bring down prices. Let me get back into the compulsory licensing question. So as I said, that works when there's maybe different companies to negotiate with, but what happens if there's only one? It's not fair for patients to get stuck in the middle, or for the government to decide it can't cover the only medication that works because the drug company will only sell it for $100,000. So this is an idea that's been described. This was an article describing government patent use, and they say it's a legal approach to reducing drug spending because actually the law for this is already on the books. Copyright law or trademark law 1184, and basically it's been around for a long time, but it already allows the government to step in and basically bust a patent and pay the patent holder a reasonable sum in order to allow someone else to use to use the patent, use the intellectual information for an important use. So this could actually happen without any legislation, and there's been a push to use this in certain cases, and advocacy groups have been trying to push the government to do this. There was a discussion of Louisiana's article in Kaiser Health News about how Louisiana had been seeking this as a potential option to provide hepatitis C drugs to its Medicaid population because it simply cannot afford to cover the price of these drugs. This is part 2 of our sort of approach to bringing down drug prices, compulsory licensing. As far as we know, it's only been sort of wielded by the U.S. government once in history, and it actually wasn't used. It was just threatened, and the threat alone succeeded. And it's sort of ironically, it happened under the Bush administration. This was in 2001. There was concern for anthrax attacks, and the company that produced ciprofloxacin, the antibiotic that treated it, Bayer, wanted a very high price, and the U.S. government wanted to stockpile ciprofloxacin in case there was an anthrax attack. So HHS actually threatened to bust the patent along the lines that I'm talking about, and lo and behold, Bayer slashed its price almost by half. So, even the threat of using this government patent use option is enough to bring down drug prices substantially. And something similar happened actually in Canada. I should say compulsory licensing is also considered legal under international law, under the Doha Declaration of the World Trade Organization, and it was also, and something similar was also allowed by the Bayh-Dole Act, which I'll get into in a second. The last, the third point, bullet point on that last slide, going through solutions, was public drug development. So what's that about? There was actually something similar in the New England Journal of Medicine recently, New England Journal of Medicine recently, about the idea of a nonprofit generic drug manufacturer that hospitals were going to set up. And the idea here is that the generic drug market, even though they deliver drugs at a lower price, has not been doing a very good job of ensuring that we have all the medications we need. These are recent headlines about all the drug shortages that have been sort of perennial problems. Now, right now, there's been a lot of issues with IV fluids, and that's been largely attributed to issues with production in Puerto Rico, where these products are made, and people sort of are attributing it to that. But the reality is that these shortages were problems that preceded that, and that are really leaving clinicians in the lurch. I've certainly dealt with this working in the ICU, and I'm sure many of you have in other clinical capacities as well. But there's been reports of opioid crises, opioid shortages, meaning not the opioid crisis we think about, but that post-op pain medications to someone coming out of surgery were in short supply, and other sorts of drugs. And again, it's not just about Puerto Rico. This was a article published in the Journal of the American Medical Association last year, and caught my eye because, again, I work in the ICU. And I remember when this happened some years back, there was a shortage of norepinephrine, or Levophed. And recent studies have suggested that as compared to other vasopressors, norepinephrine has lower mortality, better outcomes as compared to dopamine in particular. So what happened when there was a norepinephrine shortage and hospitals weren't using this? So they used this as a natural experiment to look at basically mortality for people in septic shock as compared to those not in septic shock during periods when there was a shortage of norepinephrine and during periods when there was no shortage. And basically the blue bar is no shortage and the orange bar is a shortage. And for those in septic shock who needed these vasopressors, there was a small but significant increase in mortality during the shortage periods. And that was not seen in those who weren't using vasopressors, suggesting it really was the norepinephrine and not something else. So, one way to help address this is to have a sort of backstop of a nonprofit government manufacturer to produce some drugs that are in short supply. And this has been done before. Sweden basically has a government pharmacy since the 1970s, and the pharmacy actually has its own drug manufacturing arm that makes unavailable drugs if no company makes it. And those, at least back in the day, a while back, the public drug manufacturer made more than 1% of the drugs being sold. So this is one potential solution, and it's one we include in the proposal. All right, I'm going to speak a little bit now, moving onward. And I know this is a lot of information, but I wanted to get it all in here about, and I'm combining a few different issues here about research, development, testing, and approval. So what are some of the issues here? Well, one big issue is that people are beginning to realize that many new drugs hitting the market are not actually delivering much in terms of clinical benefit. This was an article in Kaiser Health News last year that described that many patients were sort of frustrated to learn that the new cancer drugs in the market didn't actually extend survival. Is that true? It is true. And it's been seen in a number of studies. This was a study looking at 68 cancer drugs that were approved relatively recently in Europe. And they basically asked, okay, which of these drugs improve survival or are shown to improve survival? Which of these drugs are shown to improve quality of life? And which do not have evidence that they benefit either? And as you can see, about half have no evidence that they improve either. And you sort of scratch your head and say, well, what is the point of a drug if it doesn't improve either the length of life or quality of life? And many of the drugs that are available today, we don't have good evidence that they do either. Here's another study. This was done by Joel Action, again, who's co-chaired the working group behind this proposal and who's on the call right now. And Joel looked at basically drugs approved by Health Canada, and he sort of looked at the question of are they therapeutically innovative? And by that, that's defined more or less as they constitute a clinical advance over existing therapeutics, if any, that exist. So are they doing something more? And he sort of divided this up into first in class, which are medications that are sort of a new category of molecule, and not first in class. And you can see that a small minority of drugs were actually truly innovative, meaning they represent advances over existing therapies. Looking at the FDA, this is a sort of different definition, but we can see that, a similar sort of picture that of new molecular entities approved by the FDA over, long period of more than 20 years, that almost half of the drugs approved were basically of a drug in an existing class. So these are sometimes referred to as Me Too drugs. And even of the ones that are first in class or what they call advanced in class, which means it's not a first in class drug, but it got a priority review, which is an expedited pathway, which I won't get into, but even that doesn't mean that it actually does anything more than existing therapies. But you can see that the majority of drugs that are coming out that are being approved are not actually clinical advances. So we need to get not just less expensive drugs, but more effective drugs. Now, the next sort of issue to discuss when talking about drug approval, drug research and development, is the fact that we're putting a huge amount of money into the development of new drugs from the public sector, and then we're getting sort of a bad deal on the other end when we pay for it. So a recent study found that basically every one of the 210 drugs approved between 2010 and 2016, that the NIH had contributed to the development of those drugs in some way. And that contribution totaled about $65 billion per year. So we're putting a huge amount of money into that goes behind the basic science and defining targets that leads to the development of new drugs. And you might ask, well, why is it, why are drug companies allowed to sort of base these patents or develop these new drugs based on all this public research and then make all this patented and then make all this money as a result? And in the United States, at least, that's the result of something called the Bayh-Dole Act, passed in 1980. Actually in the waning days of the Carter administration. And basically this allowed publicly funded research by, if you sort of an academic center or academic lab that produces develops or does research into a new drug or develops a new drug, can basically patent that and then sell the exclusive marketing rights to industry. So this basically means the market is the monetization of public funded research. So is there another way to go about this? And we all know the sort of classic line from Jonas Salk. So, the idea of, could there in fact be a public owning a patent? And the answer is yes. So what we talk about to deal with these various problems is the following. First, to address the issue of these Me Too drugs, you can reform the patent system so that just because somebody tweaks a molecule, creates some slight variation on it, they can't patent that and get rich off of it. The infamous case of this happening was with Nexium, which is basically an isomer of an existing PPI. Didn't do anything different, and they made a bundle from it. But even going beyond that, Me Too drugs that don't actually accomplish anything better than existing drugs, if there are any, really shouldn't be approved. I mean, it doesn't mean they necessarily need to be more effective. They could be more safe, but there should be some incremental benefit over existing drugs to get approval. And that's not just to save money. It's also to make sure that all the research money is going into actually useful research to actually improve people's lives and not pad pockets. The proposal also calls for the repeal of those provisions of Bayh-Dole that allow private firms to monetize publicly funded research. Publicly funded research should stay in the public domain. And that leads me to the final part of this proposal, which might sound, to the slide, which might sound quite radical, but in many ways it's not. The idea is that the NIH, which already funds public research, it already funds basic research, can also go a step further and fund the development of drugs further down the road. So right now, the way it works is the NIH sort of funds the basic research, and then the drug company steps in late in the game and sort of takes over. There's no reason that we can't let some of this development happen purely in the public sector. It would remain in the public sector. The public would own the patent, so to speak, and there would be no patent, and the drug could be produced as a generic right away, right after being approved. And, it's interesting. Some of these things have been talked, when we first sort of got together to put this together, some of these seem like very radical ideas, and in some ways they are, but actually there's a lot more people talking about these things right now, especially the public drug development system. It's becoming much more mainstream as an idea, as a way to deal with not only excessive drug prices, but also Me Too drugs. Now, so let me get into another arena, and we're getting sort of towards the end of my side of this, then we can sort of talk, answer questions. But the question of sort of drug approval, I started to get into this about, sort of drugs having to be a clinical advance in order to be approved, but just to sort of fine tune that a little bit, what do we mean by that? Well, we mean that real clinical outcomes, things that actually a patient experiences, length of life, pain, symptoms that the patient experiences that matter for their well-being, that those are what we're approving drugs for, not so-called surrogate outcomes. So surrogate outcomes are lab tests, biomarkers, which can be useful as research tools, don't get me wrong, but, things like hemoglobin A1C, where yes, it might matter, but just lowering a number doesn't mean you're actually improving someone's health. And this was a sort of a paper that Joel was involved in, where they basically, enumerated all of the drugs that were approved for surrogate outcomes and were later found to have harm, in some cases, very severe harm. Flecainide is the sort of classic example, an antiarrhythmic that did in fact suppress arrhythmias, but it also killed people. So not what we want to be doing. The other issue in the same category of drug approval process and the drug testing process is the fact that we're still we've made many advances in terms of our knowledge of forcing sort of pharmaceutical companies to disclose what research they're conducting, what clinical trials they have running, so they don't hide results that are unfavorable. But this study basically looked at, a number of years out from drugs, from trials being completed, and looked to see if drug results of trials were available on clinicaltrials.gov or on PubMed, and this sort of a substantial minority hadn't fully disclosed their results. So let's address each of these in turn. Or how does the proposal address each of these in turn? So first, the trial data can be made publicly available and can be transparent in anonymous form, so researchers can actually understand what's happening. To deal with the problem of problems in the drug testing process. These are drug companies that are running their own clinical trials, as I said, maybe not disclosing all the data, but also sort of setting the trial up in a way that sort of set to make their drug look good. That we could start funding a lot or most clinical trials through the NIH. So have impartial arbiters basically running trials. It doesn't really make sense to have people who stand a huge amount to gain from the way a trial turns out to be the ones running it. So we think that the NIH should, in fact, run clinical trials. It wouldn't have to run it itself. It could be done at academic medical centers. They'd fund it, but that clinical trials shouldn't be funded by the pharmaceutical industry or run. And then finally, getting back to this sort of approval standards issue, drugs should really have to improve the length or quality of life in order to be approved, and not simply change surrogate outcomes, and with infrequent exceptions to that rule. All right, we're kind of heading towards the final sort of stages of this proposal. There's significant problems with the way we monitor drugs for safety problems, and things have actually gotten worse. So in 1993, a law was passed that basically meant that that drug companies would start paying the FDA fees for it to approve its drugs more quickly. And what that meant was two things. First, it meant that the pharmaceutical industry is partially funding the FDA, which, you don't have to be a sort of conspiracy theorist to imagine how that creates a sort of problematic conflict in terms of interest. But let's put that aside. It also has meant that the FDA has sort of had its back to the wall in many situations to meet these deadlines that were imposed by this law, and that requires it to approve drugs more quickly. So this was a study just looking at the rate at which drugs were either withdrawn from the market or got so-called black box warnings, and these are sort of warnings that a drug has very serious side effects, and the rate before the passage of this law and the rate afterwards. And you can see that there was an increase in the percentage of drugs that developed that went on to have black box warnings or withdrawn from the market after the enactment of PDUFA. That's the 1993 law. There's been these other problems with the way we look for safety with drugs. The arm of the FDA and the corresponding Canadian bureau that look at safety is vastly underfunded compared to the part of these agencies that approves new drugs. There's been a proliferation of new pathways that allow drugs to be approved with lower standards of evidence or more quickly. There's also been a sort of a lax approach to holding pharmaceutical companies' feet to the fire when it comes to following up and follow-up studies to make sure that drugs don't develop that are safe and effective after they're approved and on the market. So we propose dealing with this with a slew of reforms. First, there should be full public funding of the FDA, which in the scheme of things is actually not expensive at all. Less of these expedited reviews. More strongly enforce the requirements that pharmaceutical companies carry out studies about drug efficacy and safety after the drugs have come out, because many side effects aren't recognized until later. And then we need to more adequately fund the FDA to do the kinds of post-marketing safety review studies that I'm talking about to make sure drugs are safe. We also deal in the proposal with the issue of promotional spending. So drug companies spend a huge amount of money on selling drugs, on pushing pills. Joel did a study of this showing, that pharmaceutical companies are spending tens of billions of dollars pushing pills. This is for things like direct consumer advertisements, detailing physicians, free samples, etc. And overall, if you include, put marketing and administrative expenditures together, drug companies are spending more on those, which is the red line in this graph, and the y-axis is billions of dollars, billions of dollars spent, and the x-axis is just the year over time, and they are spending on research and development. Well, there's things we can do about this. First, a lot of these advertisements that I'm talking about are misleading, and this has been studied in a number of ways. And overall, these advertisements, this promotion, the detailing of physicians is inaccurate, it's misleading, and the FDA needs to have more resources, and the corresponding Canadian bureau in order to review these materials and clamp down on inaccurate and misleading promotion. We should discourage this kind of promotion by ending the tax deductibility of basically pharmaceutical companies can write off what they spend on advertising as a business expense. That shouldn't be the case. We can increase penalties for misleading promotion. We could encourage other forms of physician education. The argument for pharmaceutical companies spending all this money on educating physicians is that this is an important form of education. Well, there's other ways to go about that, and we could have nonprofits that actually provide unbiased information instead. We would actually like, similar to actually the AMA, just to ban direct consumer advertising. That's probably not legal in the United States, at least, because of the idea of corporate free speech, that there would be an infringement on corporate free speech. But there are other ways to sort of work against it. Like if there's two drugs and they both are equally effective, well, maybe only include the one in the formulary that isn't being advertised, if that's a possibility. It isn't always. Our paper includes this sort of complicated looking diagram that kind of shows how drugs would be developed, approved, paid for. And I won't get too much into it, but basically to envision this from a big picture perspective, you can basically imagine that we're talking about creating a sort of very bolstered public pathway for drug development. And we're conceptualizing this happening under a single payer system. So basically, pharmaceutical companies would still exist. They would still develop new molecules, and you see that on the far left. But what would happen is that most of these new molecules would be tested with publicly funded clinical trials. Additionally, public funds that went into the NIH, whether for basic science funding or for this new drug innovation division, well, those funds would be used to develop new drugs, and those new drugs would not be patented. It would be in the public domain, and then those would be studied by publicly funded clinical trials. All of these new drugs would be basically approved or not approved by the FDA or Health Canada, which is a corresponding agency in Canada. And then the single payer program, if you just follow this line, would decide which drugs to include in the national formulary, and it would include all medically necessary drugs. And then if you follow the arrow down, you can see that, for patented drugs, if a price could be negotiated, then that would be negotiated. It would go to private manufacturers. If a price could not be negotiated, and there'd be different metrics of deciding what was a reasonable price, the government could compulsory license the manufacturer of that drug generically. And then generic drugs would mostly be produced by generic manufacturers. But let's say Martin Shkreli comes along and decides he's going to jack up the price of, this drug used by a very small number of people, X-fold overnight just because he can. Well, maybe that drug will just be produced by the public manufacturer instead. We did an economic analysis that is not in the paper, but it is online at pnhp.org/pharma. And, there's both costs and savings from this approach. Overall, there's savings, and there's huge savings, for individuals. So basically, by lowering drug prices 50%, brand name drug prices, you'd save about $155 billion a year. But we do want to do a single payer system, cover the uninsured, and also eliminate cost sharing for the uninsured, for the underinsured. And we estimate that would increase drug spending to some extent. Then we would fund these new clinical trial division of the NIH and the drug innovation division of the NIH, which would develop new, not patented drugs. And we'd also spend a little bit more on the FDA and still produce, despite those big expenditures, $15 billion in savings. So I'm ending right at 9:50. I thought I would stop there and open it up for questions. And it looks like in the chat box here, there is a couple questions. So I'll start with those, but feel free to either say or write your questions into the chat. So do Me Too drugs make the class more competitive? So I think the idea here is that isn't it good to have more than one drug? Because then you can actually negotiate with, negotiate between these different companies as instead of one. Well, there is some truth to that. But on the other hand, it is an enormous expense to actually research and develop these new drugs. It's better to have less choices, to negotiate with one company. And if you have these additional tools like compulsory licensing, as I mentioned, that can give the government a lot more leverage in those negotiations, even if there's only one other drug. And then does marketing decrease the unit cost of a drug by increasing sales? It's an interesting question. I think that you would want to not produce more of a drug than was needed. So I think that the answer is probably no. I think drug companies set prices at what they can, and then they get it as high as they can, and then they make the profits that result from that. So I actually don't think that marketing decreases the unit price of sales. I also think even if it did, that wouldn't necessarily be a good thing. And then there's a good question here from Leslie. Are there any bills in Congress to implement any of these reforms? So one of the reasons why we put this proposal together is because we wanted a single big package that would, in fact, that could be turned into legislation that would accomplish a number of goals. And I should say many of these things can be done separately. Then many of these reforms could be done separately, and that's good. And they can even be done without a single payer system, but to do all of them, you need a single payer system. So, but I didn't. Oh, because the question is, are there any bills? So Senator Sanders has a bill that would basically set up a prize fund to incentivize the development of new drugs, and that would, in fact, be very much like what I was talking about with the Drug Innovation Division. That would basically be a very similar thing. So that bill from Sanders is, in fact, would sort of accomplish what we're talking about in that one area. Additionally, there's of course HR 676 and the Sanders single payer bill that would accomplish the other the goal of drug negotiations and universal coverage. They also would mostly in the House bill would get rid of all cost sharing. Sanders bill gets rid of cost sharing for everything but drugs that it retains small drug co-payments for drugs that are not considered preventative, whatever that means, but accomplishes a lot of this. All right, so we have a question here. Yes, so a question from Susan, and Susan asks, shouldn't we push for a new drug to show that is better than one that is out there? And that's one thing that we do say. We ask, we certainly in the proposal say that, you know, for drugs to be approved, if they want to be approved, if there is existing drug for that indication, then they should do better than the existing drug. Sometimes there isn't, and then they would only need to do better than placebo. But Susan, yes, if there's already a migraine drug, if I want to get my migraine drug approved, it should be better than the existing migraine drug, because why else do we need another migraine drug? If it is somehow different, has less side effects, is easier to use, that's different. So Jonathan asks, what we do with prescription benefit managers? Well, I mean, so they are part of Medicare Part D, and that's right. So Medicare Part D is, you know, was created in 2003 with the Medicare Modernization Act, and basically that you know, rather than sort of making the drug benefit of Medicare just be part of Medicare, it sort of outsourced it to these companies. And you know what? It's created a huge amount of waste. Prescription drug benefit managers are in the news a lot recently because in many cases they actually benefit from having higher drug prices because they get paid as a slice of the sticker price. So the reality is no. I mean, there would be one big prescription benefit manager, that would be the single payer, and it would do the negotiating for the whole country, and the waste wouldn't be there. So basically there would be one big PBM for everyone. A question about would for-profit drug companies be allowed to exist. So yes, the proposal we're outlining would create a new public pathway, but it would not end the private pathway. So this would be sort of an alternative within this system. But drug companies would still exist in the way that we've outlined this. But they would be regulated. They would be you know, much more tightly regulated, and in addition to being more tightly regulated and their prices regulated, there would be a new public system that would be developing drugs that outside of the patent system, outside of the private drug company system. So we have another question here from Leslie, and we only have a few more minutes. That asking if any national medical professional organizations have endorsed these reforms. Are there any model position statements? So it's a good question. I don't. So certainly nothing, you know, similar to what we have here. And you know, one of the first steps is getting national medical professional organizations to endorse single payer, because this builds on single payer. You know, there are certainly certain provisions that are endorsed by some of these reforms. As I said, even the AMA is against direct-to-consumer advertising. But no, but this is really the first step, we hope, in disseminating these kinds of reforms and pushing organizations to adopt them and to endorse them. I don't know if I just want to make sure if Joel was on the line and he had anything to add. Joel, please just pop in or you know, let me know if you wanted to add anything. So we have another question here from Miles. So basically, how would you stop a company from making a new drug that turns out to be Me Too? even though the company spent the effort with the hope that the new one would have an advantage over the others in the class. But it didn't turn out to. So, I mean, that happened, right? So what happens if I put a lot of money into developing a new drug and it doesn't work? Well, then I can't, I mean, then I'm out of luck. That's just the nature of the game. It happens all the time. The majority of new drugs don't actually have, don't wind up to pan out. And that's just the price of doing business. So, yeah, it's no different than if the drug failed. It's basically a failure. If I make a drug and it does nothing more than the existing drug and nothing better, and it's not safer, and it's not easier to use, and it's not less expensive, then there's no real reason for it to be around. Joel, thank you very much, Joel. Joel pointed out that I think I said insulin was discovered in the 1930s, and I appreciate that's not right. It was in 1922. So I apologize for that error. But it was in Canada, so I got that part right. I really, this was really great to talk about this. I hope, these 1 hour sessions is always a lot to both do the talk and to have a full discussion. But I hope that was useful. Me and Joel's very available if anyone has any questions. This is really just the beginning of, a new discussion about drug costs and making better drugs, and I think it's going to remain a major issue in the days ahead. I'm looking forward to working with everyone and fighting for a better pharmaceutical system. I think I'm probably, since it's just about 10, I think I'm going to stop on time. It's pretty late, especially for the East Coast people. And thank you so much all again for joining, and I hope everyone has a lovely evening. Take care, everybody. Bye-bye.